Hi everyone, my name is Promise. I'm a fourth year medical student. My voice is a little scratchy because I feel like I'm having a sore throat, so hopefully I don't get sick. But this case is actually a human DX case, but it's very similar to a case I saw recently at my away rotation, but unfortunately I don't have Epic access for that anymore, so I found this case to present.
Thanks, Promise. I hope you feel better and don't get sick.
Okay. The chief complaint, so this is a 19-year-old female who presents with she feels fatigue and then myalgias in both of her upper arms. And then she also noted having some rash in both of her lower extremities in the shins. Oh, and that's for the past week.
All right. Well, I can take a quick pass at this and then hand it over to Jack and then get more information from Promise. So we have a fairly young person who is presenting with some non-specific symptoms of like fatigue, myalgias, and a lower extremity rash. You know, when it comes to fatigue, myalgias, again, very non-specific. However, you know, we're in the season of a lot of like viral syndromes that can have presentations like this of fatigue, myalgias, and some of them accompany like viral symptoms. So I think like common things being common, that's one of the things to think about. However, depending on the rash itself, depending on this distribution, and also uh, kind of like her other symptomatology, we might have to be dealing with something sinister in the realms of autoimmune disease, in the realms of even malignancy. However, her younger age makes that a little less likely. The other thing that I always like think about with whichever like young person presents, again, young people tend not to present to healthcare as much, right? Young, healthy. So a lot of more like congenital familial syndromes might have captured them until their first interaction with the healthcare. So that's another thing to kind of think about, is that is there anything else in the background that we might not yet be aware of? Jack, anything else to add?
No, I have nothing else to add at this point. I think yeah, you absolutely covered everything that had come to mind. I'm super excited to see how this case unfolds because as you said, tis the time of the year for the common stuff, but also this is potentially the beginning of something potentially a lot more complex.
So to give more HPI, she noticed that she had multiple bruises on her shins and then thighs, and then forearms, and then she had a blood blister on her inner lower lip. And she also mentioned that 3 days ago, she started having heavier than usual menses. She went through tampons that would be getting soaked in less than an hour, and then she had to use many like multiple tampons in a day, and she used to use pads. And then a day ago, she also developed intermittent sharp abdominal pain in the epigastrum, and that spontaneously resolves after a couple minutes. She also tested COVID negative at home. In terms of review of systems, and she had a recent upper respiratory tract infection about a month ago with some coughs and sputum, and then has some sore throat for 2 weeks. And she also endorses generalized fatigues. Um, and then the skin rash that I mentioned in both of her calves. And then in terms of her past medical history, she has asthma, GERD, and recurrent UTI. There's no previous history of any kind of abnormal uterine bleeding. There is no current medication use, and She's had a cholecystectomy before. Family history wise, her maternal grandmother had skin cancer and MI. Otherwise, no, nothing remarkable. And then she'll show in sexual history. She lives with her boyfriend. She is sexually active with her boyfriend, and they do not use any contraception. She's never been pregnant or been diagnosed with any STIs, and she smokes tobacco. She denies any other recreational drug use or alcohol use. I'll pause right here.
Whew, all right. Well, this certainly sounds like it's more than just a general run-of-the-mill URI, and so we will try to tackle this really rich and detailed history. Promise. Thank you for just again such a thorough but also really well synthesized delivery of what's clearly a whole wall of information here. I think what this aliquot really helps us do is it helps us clarify the problem and get a much better ability to characterize what the rash is, right? It sounds like what the rash that we got in the first aliquot is actually signs of petechiae and potentially some blood blisters developing as well. And when we see petechiae like this, both, or I should say what sounds like a petechial rash in the lower extremities, as well as what sounds like some abnormal bleeding in other mucosal surfaces of the body, including the genitourinary tract, as well as the oropharynx, we start to move into the space of a coagulopathy. And coagulopathies can be due to quantitative or qualitative problems with either platelet numbers, or I should say with either platelets or with the coagulation cascade. Qualitative problems are going to mean that things are not functioning correctly, right? There is, for some reason, platelets are not binding well, or for some reason, the coagulation cascade is not binding well. Quantitative problems are going to be due to the number. So there is thrombocytopenia, or a low amount of platelets, or there are deficiencies in certain factors within the coagulation cascade. Those two buckets, again, quantitative or qualitative problems with elements of the coagulation system, will make up for the bulk of coagulation problems. But there is a third category that we should at least keep in the back of our mind, particularly if we discover that there's bleeding out of proportion to the degree of quantitative or qualitative abnormalities, or if she ends up having normal coagulation levels. And that's going to be problems with the vessels. And problems with the vessels can be related to vasculopathies, which could include things like vessel friability, which we can see in rare nutritional deficiencies like scurvy or some deposition diseases like in amyloid, or with the possibility of a vasculitis. In other words, there's inflammation within the blood vessels that could be causing abnormal bleeding problems. And while we should be directing most of our cognitive energy towards the coagulation issues, again, quantitative or qualitative problems in platelets or coagulation factors, the post-URI nature of this disease process, plus the presence of abdominal pain, does bring some vascular diseases into the fold here, particularly something like IgA vasculitis, which oftentimes comes after an upper respiratory tract infection and can have an intra-abdominal signature to this as well. So I think we can use some of the other information in terms of her background risk factors, but that sort of can give us a general architecture for how we can explore this problem. Is there abnormal numbers of platelets or coagulation factors? Are they not functioning well, which we can see in the presence of a factor inhibitor or in the presence of something like von Willebrand deficiency? Or actually, is this a vessel problem, which again, the vessel could be friable or the vessel could be inflamed? Sharmiz, what are you thinking here?
Oh, no, beautiful discussion. I absolutely loved everything you said. So kind of looking to her like past history, to layer on that, I think like nothing that really makes me worried about any risk factors in terms of past medical history. The only thing that I was noting in terms of like the past medical history, that she has had a history of a cholecystectomy. And I often see that in like older adults. So interesting that a 19-year-old had her gallbladder removed. And then the question that pops into my mind, it might be a red herring or it might be related, is like, why is this young person has had stones? And thinking about like, hemolysis or other risk factors that can increase your risk of like stones. So something to note of, again, might be related, might be not. The other thing that I think is worth keeping in mind as we go forward is in terms of our health-related behaviors. This is someone that, I would do a pregnancy test. So she's not using any contraception. She's sexually active. And the other thing to think about are like STIs, gonococcal infections can have a rash associated with it. So it can be quite systemic. So thinking about, a pregnancy test and STI screening as we move forward.
Yeah, fantastic discussion. I love the coagulopathy discussion by Jack, and I also really love how, Sharmin, you didn't overlook the history. You were taking pretty careful consideration, especially the social history. So in terms of the vitals, her temperature is 98.2 Fahrenheit, heart rate is 91, respiratory rate 16, blood pressure 118/80. Oxygenation is 100% on room air. And then she appears well nourished, well developed, no icterus. There are multiple flat, red, non-coalescing lesions on the soft palate and inner lower lip. There is no cervical lymphadenopathy, and her abdomen exams actually soft, non-tender, normal active bowel sounds, and no hepatosplenomegaly. Her pelvic exam, there's blood in the vaginal fault, no trauma, no bleeding from the cervical os, and no cervical motion tenderness. Extremities, no lower extremity or upper extremity edema, effusions. Skin-wise, there are extensive flat, red, non-blanching, non-closing dots on the bilateral lower extremities on dorsal feet, shins, and calves. On bilateral upper extremities on the dorsal surface of the hands, and ecchymoses of various sizes on bilateral mid-thighs and bilateral forearms. There is no pallor. And I can pause here, or I can give like a first set of labs.
Do you want to give us the first set of labs too? Thanks, Promise.
Yeah. So white blood cells 5.6, hemoglobin's 10.8, hematocrit 32.7, platelets is 2, and there's no baseline CBC for comparison. CMP, sodium 141, potassium 4.2, chloride 108, bicarb 27, BUN is 8, creatinine is 0.7, glucose, AST, ALT are pretty much within normal limits. T-Billy is 0.4, and then I will pause here.
All right, thank you, Promise. I'll take a pass at the exam and then hand the mic to Jack for discussion of the labs. So, always vital signs are vital. Taking it past at that, I'm just noting that our heart rate is a little bit on the higher side in the 90s, and her blood pressure stable. Oftentimes for a young female, that tends to be in the normal range, but it's worth looking at her prior blood pressures, if there are any in the system, to make sure that delta is not big, because we're worried about someone who is bleeding. And oftentimes, young people have good reserve, so they might not show as much abnormalities, but worth keeping a close eye on. In terms of like her exam, I think is like most notable for her skin exam, and the lesions in her mouth, again, kind of paints a picture that we're worried about bleeding in this person. Looking at her lower extremity exam a little bit closer, the non-blanching rash that's on her both upper extremity and lower extremity. Again, it seems like a blood that is in the extravascular space in the sense of non-blanching. If it's like palpable, non-palpable would be helpful. So thinking about if you're dealing with like palpable purpura and like more vasculitides or petechiae. oftentimes like independent area, sometimes like having petechiae is within normal, however, not in your upper extremity and all over. So again, kind of pointing towards a more platelet the disorder. And with that, I'll pass the mic to Zach.
Awesome. So yeah, building on, I think, the phenomenal foundation that Sharmin laid for understanding how her exam sets us up for really suspecting the coagulopathy that we got some flavor for in the HPI, right? We have labs that now really give us a problem space that we can start to work in, right? The exam supported our working hypothesis that indeed there seems to be a bleeding problem. And then our labs give us some insight into where within the coagulation system that bleeding problem lies. And it seems that at least a prominent driver of this is going to be the platelets, right? Because we have not just thrombocytopenia, we have severe, profound thrombocytopenia with single-digit platelet counts. And this degree of thrombocytopenia really prioritizes the possibility of immune thrombocytopenia. But before we settle on immune thrombocytopenia, it's important for us to pass through the consideration of some other potential morbid causes, not just of thrombocytopenia, but what we really have here on the CBC, which is anemia plus thrombocytopenia. So whenever we see the combination of anemia and thrombocytopenia, we want to at least pause and ask ourselves a couple questions. One, could there be a microangiopathic hemolytic anemia here, right? Whether that's something like DIC, TTP, HUS, or one of the other thrombotic microangiopathies. And most importantly, we want to at least ask ourselves, is there any possibility that this person could have received heparin recently? Because heparin is one of the things, heparin-induced thrombocytopenia can lead to the development of a combination of anemia and thrombocytopenia. And not only can it have bleeding complications like what we're seeing here, but there could also be devastating thrombotic complications that patients develop down the road. And so if we at least ask ourselves those two questions, it leads us to send and at least consider some important diagnostic tests. We'll look at the blood smear to see if there's any schistocytes to increase the probability of a microangiopathic hemolytic anemia. And we'll look through her recent medical history to see if there's any possibility that she has received heparin. In the absence of a known DVT or VTE and recent hospitalization, the heparin hypothesis starts to dissolve relatively quickly, and then the smear will be able to get some of that data quickly. And if both of those come back negative, there's not a strong suspicion of a MAHA, and it doesn't seem like there's any heparin, then we can really invest our cognitive energy into focusing on what could be driving the platelets down this low. Now, again, we said at the beginning that the probability of ITP is quite high here, and that's because of the degree of thrombocytopenia that we see here. When we have such severe thrombocytopenia out of proportion to the degree of anemia, it really makes us think, gosh, there's something that's preferentially destroying platelets. And the things that destroy platelets this aggressively are usually autoimmune diseases. So let's just talk briefly, are usually antibody-mediated destruction of platelets. So let's just talk briefly about how we can think about ITP overall, because in addition to treating this, we also want to see if there's any secondary cause that we may need to diagnose and treat as we go forward. So I would say that the vast majority of cases of ITP that we encounter in practice are going to be idiopathic or primary ITP. The body just happens to develop antibodies to platelets that go on to destroy them. But about 20% of cases have a secondary cause. And for that secondary cause, we can use our usual I-MADE mnemonic to help us organize the potential secondary causes, right? So this could include infections, which are primarily going to be viral infections, things like upper respiratory illnesses like mono or EBV, and then other mono-like illnesses, things like CMV or HIV, are also going to be some of the other infections. We can sometimes see it associated with non-respiratory viral illnesses, which could include things like the viral hepatitis. And then rarely we can see it associated with some gastrointestinal illnesses, for example, things like H. pylori. Moving on from the infection category, right, there's going to be some autoimmune diseases that we can see do it, particularly connective tissue diseases like lupus. There's some cancers that can do it, primarily lymphoproliferative disorders like CLL, which we wouldn't necessarily think about in somebody who's this young, but really probably any of the bloodborne cancers can do it. And then certain drugs can do it, most notably antibiotic exposures, which sometimes we might want to go back and say, hey, wait a second, she had this URI a month ago. let's make sure she didn't receive an antibiotic like a quinolone during that phase, because that can sometimes set people up for ITP. And then finally, a couple other scenarios that can do it. One of which Sharmin already mentioned, which is pregnancy. Pregnancy can cause some different bleeding abnormalities, and can also be one of the secondary causes of ITP. So if we think about this arc for us here, then, right, we're going to look for the MAHAs, make sure there's no heparin, and then start to explore the possibility of some of the secondary causes of ITP, particularly upper respiratory illnesses like EBV, CMV, and mimickers of that, like acute HIV. Certain autoimmune diseases like lupus. We'll keep cancers in the back of our mind now, and then make sure we're not missing an underlying pregnancy here, because that certainly is going to change some of the different medications that may be safe for her as we think about treating this down the road. All right, Promise, take us forward here.
Yeah, great discussion, Jack. I love your approach and also discussing things that you never want to miss with thrombocytopenia. So in terms of the infectious workup that you mentioned, like the EBV, CMV, like hepatitis, all of that came back negative. HIV is also negative, no heparin use. Her urine pregnancy test is also negative. And then with the smear, there is profound thrombocytopenia, where rare platelet stains, no platelet clumping, no evidence of hemolysis, no blasts, no schistocytes. And we also got some ESR, CRP, they're all within normal limits. And then hemolysis labs does not suggest there is hemolytic anemia process going on. Iron labs, the ferritin is 7, iron is 21, transferrin is 7.9, TIBC is 269. And I can review the final diagnosis, or do you guys want to talk briefly about this and then final diagnosis?
Yeah, thank you so much. I promise. We can maybe discuss and then hand it over to you. Thank you so much for presenting such an educational case, by the way. So kind of going through for the labs again, really grateful for the thorough infectious workup. I think HIV, the pregnancy was definitely a no misdiagnosis here. So grateful that that has been done. So I think in terms of the other thing that I was just thinking is that I would probably get a INR and like a PTN, PTT. Again, things you don't want to miss, as Jack mentioned, is MAHAs and DIC. Oftentimes you might not see schistocytes, and then you want to make sure the fibrinogen, the coagulation, if you're not dealing with a DIC type picture, which doesn't seem this is the case. I think when you see the platelet stuff too, I love Jack's framing of ITP is a diagnosis of exclusion. So if you want to go through all of these things, but it kind of smells like ITP. And thinking about the secondary causes of it, I think it's fair to think it probably most likely is idiopathic. I can't think of any other secondary causes. Lupus is a great idea, given her age, probably worth sending an ANA to think about that. Hepatitis C, again, in this age, might be a little less common to see that. The other thing, with HIV, you want to make sure she's not in the window period that the test might not be accurate. So it's worth repeating the HIV test down the road again. So I think I really want to treat her for ITP. The other thing I want to make sure, going back to her presentations, and her intermittent sharp abdominal pain, may be worth doing a pelvic ultrasound again I know the pregnancy test came back negative, but make sure there's not ectopic maybe. And the question is whether a 19-year-old you would CT abdomen and pelvis to make sure she doesn't have any intra-abdominal bleeding. She's hemodynamically stable, feel less concerned about that, but I think I would definitely do a pelvic ultrasound in her. Jack, any other thoughts?
I have nothing to add. You covered everything I was thinking and then some. So yeah, I'm excited to see what the final diagnosis is.
And yeah, in terms of ITP treatment, oftentimes IVIG are good friends with steroids, and thankfully we have wonderful hematologists to rely on as well. So I'm curious to see what they did promise.
Yeah, so he was originally consulted, and she was diagnosed with presumed ITP, and they started on steroids, dexamethasone 40, and then also gave IVIG for 2 days. And at that time she has like her menorrhagia has significantly improved. And her platelet counts have also significantly improved. Um, so the final diagnosis is ITP. And in terms of like a couple pearls that I learned is the just when someone has ITP, like the presentation can have that mucosal bleeding, but in the patient that I saw in my away rotation, he actually developed some neurological deficits, and he had a CT scan that showed a ring enhancing lesion. And something that I learned from that was the coagulopathic bleed, the mucosal bleeding, can also end up in like a ring enhancing lesion type of picture, and that can lead to. So when you have ITP and when your platelets are so low, you always have to be worried about that as well. Um, so that was probably the biggest pearl, and also just the reason for getting like hemolytic anemia labs, besides the patient have anemia and then in the setting of this heavy menstrual bleed, it's because there is something called the Evans syndrome. And that was the reason for getting that. And then also the never missed thrombocytopenias, which Jack covered very well, the TTP, HUS, MAHA, DIC. Those are the things that you never want to miss. Yeah.
Thomas, thank you so much for this case. I think I just the journey of it from rash to ITP. I think it's such a humbling reminder, both of the importance of the physical exam, just in terms of being able to characterize the rash, but also the value of some of these just sort of general organizing frameworks, not only for diagnosis but also for management, because ITP can have a very challenging management pathway to go down. And it's wonderful and a huge relief that the IVIG and steroids did the trick for her, because in the absence of those, some of these more invasive or potentially more immunocompromising medications become necessary, which I would feel terrible if a 19-year-old had to be exposed to that. So much to learn from the case itself, and I think my hope is that for everybody there'll be even more to learn as we all get to reflect on this case that you brought us today. So yeah, thank you so much for the case. Ashutosh, thank you for the professional level scribing here, and really excited to pass it over to you, Mariana, for the teaching points, and most of all, grateful to you, Sharmin, for being a co-pilot again for this case today. It was a blast.
Thank you, Jack and Sharmin, for this amazing discussion. Thank you, Promise, for this fascinating case and really educational. And so let's go ahead for the teaching points. We had a young patient with non-specific symptoms and rash, and we have to think in the common causes first. So we considered viral syndromes and the rash characteristics and distribution could help us with the diagnosis. But we also had signs of petechiae and blisters, so we started to think about abnormal bleeding and coagulopathies. And in this case, we have to think in qualitative or quantitative causes. And we also could have a problem of the vessels that could be inflammations, such as vasculitis, for example, or nutritional deficiencies. And the patient also had a post-URI associated with the abdominal pain. And in this case, we have to consider EGA vasculitis. And Sharmin also noticed that this patient was a young patient with past medical history of cholecystectomy. That's not usual. So we have to think about hemolysis, familiar causes of increased cholesterol. And the patient also as I've already mentioned, is a young patient, so we have to consider STIs, and STIs can appear with associated rash, so we have to consider that too. And then after the labs, we found out a profound thrombocytopenia, so we have to think in immune thrombocytopenias. But first, we have to consider mainly because we had anemia associated with thrombocytopenia. So we have to ask, could this patient have MAHA, or such as DIC or TPP? So the blood smear could help us here. And we also have to ask, could this patient have received heparin recently? If the answers are no for both of these questions, we should start to think in ITP. And important causes of secondary ITPs are infections, autoimmune conditions such as lupus, malignancy, such as CML, that would be less likely because of the age of the patient, and also drugs and pregnancy. And to wrap up this amazing presentation, Promise taught us about a different presentation of ITP that could be a ring adhesion lesion in the MRI. And that's what I have for today. Thank you.
All right. Thank you so much, Mariana. Thanks everyone for joining us today. Wishing you a wonderful rest of your morning, afternoon, evening, and all of what is left of your Wednesday. And we're excited to see you for another VMR tomorrow. Have a good one, everyone.